Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
So I would like to welcome Professor Lars Bullinger from Charité University Medicine in Berlin. And he's going to talk to us about how we can actually look at the progression from MDS to AML with respect to genetics. So please, Lars.
Yeah, hi Kirsten, thanks a lot for the invitation to be with you today. And I'm happy to give you, let's say, my view of things. As many or I think almost all of you are aware, recently there have been some changes. We now have the new WHO classification. Now we have a new category or the clonal hematopoiesis of indeterminate potential made it into the WHO. It's called myeloid precursor lesions, that cohort. And then we also already distinguish we take into account the clonal evolution when CHIP develops towards MDS. We have also the category of CCAS, clonal cytopenia of undetermined significance. And then if we look at myelodysplasia, it's now called myelodysplastic neoplasms, even though we still stick to the same abbreviation MDS, myelodysplastic syndromes, as in the past. But here the novelty is now that we have more genetically defined subgroups, and in my opinion, also the classification became a little bit more easy, straightforward.
Yeah.
And then with regard to AML, there's also more genetically defined cohorts, and there the problem or what makes our life a little harder is that we now have the WHO and the international consensus classification. Perhaps we can also talk about that.
I think maybe we should talk about that later, because I really think that is a challenge for many clinicians at the moment, right? So, yeah. But also the new category, the myeloid precursor lesions. I mean, how do you place that in your own institution? Do you see these patients, or is it?
Yeah. So, I mean, of course, as more and more sequencing is done, right? I mean, they are then also detected by chance. Very often they are also detected if, for example, patients are screened for other cancers. The question is, what do we do with that? Whom should we consider for watch and waiting? And then, of course, also it will become more and more an issue if you think of autologous or allogeneic transplantation.
Sure.
What to do with those lesions there as well? Huh?
Yeah, exactly. Yeah. There's a lot of new things to learn there still, I think.
Yeah. So, I mean, I think what is known so far is that the older we get, we acquire like every 10 years, 1 to 2 new mutations in our hematopoietic stem cell compartment. And I think then if one of them takes or provides that proliferative advantage, and we accumulate them. Another thing I think we have to learn more about and to consider is then, of course, also if, for example, you have clonal hematopoiesis with the T53 mutant subclone and you are diagnosed with breast cancer, for example, do we have to also take more sophisticated care of these patients?
Exactly. Yeah, maybe we need to choose another different kind of treatment, right? Sometimes. Yeah, so I think there's a lot of things to learn there, and also sometimes it's an advantage to have clonal hematopoiesis, as I understand it, right? So this I think was shown in your institution also. So
yes,
in transplantation, right, in donors. So
yes. So nice work published by Frederick Damm's group. Yeah.
Exactly.
But the interesting thing here, there was some slight increase in let's say, transplant-related leukemia or leukemia from the donor-derived leukemia. It was slightly elevated, but on the other hand, the risk of relapse was lower because of this more inflammatory phenotype, and I think this favors GVHD, and therefore the leukemic clone might be controlled better. So
exactly.
Definitely double-edged sword, or advantages and disadvantages. But the question is, what do we do then with CCAS, right?
I think that's a very interesting group of patients, because those we do get referred all the time, right? Because they have cytopenia. So how would you handle that in your institution?
So usually we monitor them closely, watch and wait, and but also depending, of course, also how I mean, you always have to take into account how the patient feels about the disease. I mean, for many of them, there is something wrong, right? And they have a problem with waiting and just watching it, whereas others, don't want a treatment anyway. It's a difficult.
So and also I think, it's sometimes a problem we really don't have anything to offer them. So do you think this is a new area for clinical trials? Maybe if we can.
Definitely, I think we have to collect more data and do prospective trials. Completely agree, and of course also monitor the disease perhaps more broadly with novel innovative technologies to capture the clonal evolution, and perhaps we can identify new markers that let us distinct the ones that are really at risk for moving forward versus the ones that are stable.
Yeah, because one thing I also think now when we talk about clonal hematopoiesis, at least for most cases, we don't think about the additional structural variations so far, or the mosaic chromosomal aberration. So I guess maybe when we have the whole puzzle, maybe we can identify some patients that are more at risk.
If you think how fast these technological developments are moving forward, I mean, now with novel or fourth generation sequencing technologies, I mean, there's benchtop sequencers that even allow you to do a genome overnight to capture the structural variations, such as specific biosciences or nanopore. And also those technologies get better and better with regard to the single nucleotide variations, so that we also can comprehensively capture them and do not only have to rely on panels anymore, because here we also see how things are moving forward. I mean, if you think of the ESMO guidelines, there were already many mutations described, but on the other hand, if you look in current reviews, of course, there's many more MDS-related mutations that have been reported so far. They tend to cluster, of course, into the gene categories that are linked to clonal hematopoiesis, the epigenetic regulators, the spliceosome genes, cohesin complex. But then, of course, we also have these mutations in transcription factors that predispose to MDS, which you already can have as a child, right?
Yeah, exactly. Yeah, that category is also growing quite significantly these years because of the whole genome sequencing and these studies. And I think one important or interesting thing there is that you see it also. I mean, that you discover it in elderly patients.
Yeah, this was the most amazing thing for me. For example, if you think of DDX41, right? I mean, that can take 50, 60 years until you then, or to acquire that additional hits to then transform you into an MDS or an AML. Yeah.
And I think it's interesting what it will do to families that we find these things, at the late time. It's
that's true. I mean, that's definitely a good thing to point. I mean, if you think how short really we are of geneticists who can do the counseling, and I think this is an area where I think hematologists, oncologists really should be trained on.
Yeah, I think that's a very good idea.
To do that ourselves in the future.
Yeah, that's a good idea. We'll make a course.
Yeah, definitely. Especially as if you now look at the WHO classification, and those mutations really also make it into the classification, right? There we now have the new category with SF3B1 mutations and low blasts, and also the important category, in my opinion, with biallelic P53 inactivation.
But I think the nice thing about this, I mean, this scheme you have here is that it actually, it makes it more clinically relevant and a little bit more simple than we were used to, I think, when we had MDS classifications. And I think it's really nice that there is now this consideration of what is clinically relevant, because otherwise for clinicians this has been a nightmare actually sometimes with MDS.
I fully agree. And before I became a hematologist, it was always hard to understand MDS, right? As a medical student.
Sure.
Yeah, definitely. Also, I think the categories are more straightforward. Of course, there is still this discussion And this is perhaps what we will talk about at the end. So when is it still an MDS, and when is it progressing really into an AML, and when should the treatment
be directed?
Yeah.
And I think classifications are nice, but of course patients are different, right? So I think
yes, and on the other hand, this is how the biology is. It's really a continuum, right? And while some diseases might still already behave like an AML with 11% blasts, others with 18 perhaps are much more stable, and you're still on the slope.
And actually, GDX41, you can have 30% blast and still behave like an MDS.
Yes. So I think it's definitely that the blast count can guide you or help you, but it's not, I think, definitely answering the question, or won't give you a definite answer. So I think we have to better understand the biology and the molecular aberrations. And what very often you see, if you look at the disease, that then perhaps you already see mutations that are clearly linked to leukemia, such as NPM1 mutations. And my understanding is then you still have the bulk is the MDS clone, but one of them already transformed. And then you have already an AML subclone within your MDS. But then for me, that definitely would be an indication to treat the patient, such as, the NPM1 is one example that very frequently also can arise on let's say, clonal hematopoiesis or CCAS or MDS, with very often driven by these epigenetic drivers.
I think this is a very important list you have here, actually, because I don't consider, except for DNMT3A, I don't consider any of these genes associated with MDS. It's, for me, this is really AML.
Those are the drivers in AML.
So this is really important to keep in mind.
Yeah. Mm-hmm. Yeah, so if we now talk about AML, this is where I'm then again much more comfortable. As you know that I'm coming more from the other side. There we also had some changes, but what I like here also in the new WHO classification, and the same is true for the ICC, that on one hand, we increase the new knowledge we have from these sequencing studies, from the better understanding of the molecular biology of the disease. So there is also more genetically defined AML subgroups. And the most important thing for me here is this new cohort of myelodysplasia related AML, where they now, we had that before, it was called MRC, myelodysplasia related cytogenetic abnormalities. But the novel thing here is that now also the molecular genetic mutations make it into the classification. That also makes that cohort much more objective to be determined.
And actually, that cohort, don't you think that they all come from MDS, or?
Oh yes, definitely. I think they all come from MDS. Yeah. Also the ones where no MDS was reported in the past, because if the patients are having this indolent disease for several, how many patients don't? Same thing for CML, right?
Yeah, it depends on when you meet them.
After 4 or 5 years, where you would think, okay, didn't they realize?
That gives me another question, because then do you think we'll be able in the future actually to prevent maybe more? Because now we know with these sequencing techniques that we actually can introduce preventive medicine, prevent AML.
That's also a very good question. I think there, if we move forward, or if you think of the new opportunities which we also have, let's say, if you perhaps could design strategies, ways to eliminate that clone who has the proliferative advantage, and only that clone, right? If you think of, for example, genetically engineered TCRs that are targeting only, for example, mutant DNMT3A, but not the wild type, and I think,
and maybe target the MPN clone, and then maybe it doesn't matter so much if you have a background of a TIP2 mutation. But
there, for example, I think this was work published by Scott Armstrong in his mouse model. If he starts the menin inhibitor early, he could eliminate that clone. Pharmacologically, I think it nevertheless will be difficult, but I think all these immunological treatment approaches that are now appearing also with the new genetic engineering possibilities might allow us to do that.
That's very interesting, I think, the immunological part. Maybe we'll be able to vaccinate or something like that.
Vaccination is another good opportunity. Yeah, definitely. But I think we need the immune system and learn more how it functions to take care of it. But that, of course, if you think of clonal hematopoiesis also in a stage earlier, it also could make then the cardiologist unemployed one day, right?
Yeah, that would be fantastic.
Cardiovascular risk. So it will have many benefits. Yeah, and I think then the only difference here, or the problem we are now facing for AML, is that we now have two classifications, right? We also have the international consensus classification with regard, it's this hierarchical model. So we first look at the AML defining genetic abnormalities. I think that the overlap is almost 100%. Then you have the P53 mutant ones, and then the ones who have the molecular genetic and cytogenetic aberrations that are linked to MDS. But here now you have always this additional subcategory MDS, AML with myeloid dysplasia-related gene mutations if they have 10 to 19%. So that gives you the freedom to treat them either as MDS or AML.
Yeah,
it's making our life a little harder, or more, not harder, perhaps more complicated. You can see it both ways. You have more opportunities, but once in a while, it's difficult to decide.
But I think from my perspective that there could be an issue with MDS patients being older and having more comorbidity and so on. They might fit into that box. But I think it's so important that you look at, they might have the right mutation, but they can't tolerate the treatment, right? The AML treatment is probably often more aggressive, right? And I think that's where I think the big issue is. And I think maybe, do you think in the future we could make a new classification where we actually, like artificial intelligence, I don't know, where we actually also include the patient's, physical state?
Yeah, I think for the younger ones, in the past, many study groups already treated these MDS RIPE2 patients aggressively, right? There, I think also we need more retrospective studies to look at the outcome of those patients. On the other hand, as you completely right, for the older ones, you still can have patients with higher blast numbers where the disease still behaves not aggressively, right? I think the understanding of what additional drivers are there. I think also the gene-gene interactions might tell you a little more who will be rather AML-like or MDS-like. And I think there we still...
Even though they are AML-like,
to learn more.
It's sometimes quite limited, right?
That's true. But of course there, we now have with venetoclax a good combination partner for hypomethylating agents, and that of course also might be relevant in MDS. And then if you also think of the more molecular targeted therapies like targeting IDH, and there perhaps is I hope there's more to come. But
then I think it's very important that MDS and AML doctors collaborate more, because I think in many institutions it has been different doctors treating one thing and the other.
Yes.
I think really need to have like a discussion about this group,
especially as those diseases are so tightly linked. They definitely should collaborate and work together. I fully agree.
One thing I think, so these new classifications, are they more helpful than for us in deciding who we're going to transplant, do you think? Or because I think that's always for MDS, obviously that's so important because it's the only cure.
Yes.
So
I think they can guide treatment decisions. But there also, of course, the question then always will be, first try to get rid of the clone, or you move directly into transplant, right? That's a whole,
that's a whole...
If you think of ASH, the study that was presented also by the colleagues from Dresden, also even for AML, that is now open for discussion. I think we have to, perhaps it can help to define the ones that are chemo resistant from the ones that are chemosensitive. The chemosensitive ones, if you think that they are AML, MDS-like, I would also, if they are termed MDS, rather try to get rid of the clone and then go into transplant. For the other ones, I think we need new strategies, especially if you think, for example, of the P53 mutant ones.
Oh yeah. I think that will always be our headache, right? I mean, what to do with that? Yeah.
For some more years, but then hopefully with a new.
Hopefully we will find out. Yeah.
Immunological approaches, new antibody-based treatment targets, like CD47, perhaps that can help a little bit.
Yeah. The immune system is what we have to rely on there, I think. Yeah. Good. It was very nice to talk to you, Lars, and thank you very much for your time.